it really is a special afternoon for us here. And this lectureship really represents a role model in many ways of the amazing collaboration that occurs in Winship, not just among the physicians and the scientists and the caregivers, but actually the families and our teams here. I had the privilege of taking care of Mr. Puri many years ago and for a long period of time, and I think the family's relationship with Emory since that time really represents a fundamental bedrock of how we take care of patients here, and that is patients become our family. And this memorialization of his life and all that he's done through education by bringing speakers, famous speakers from the outside, really does absolutely cement that relationship in my mind. And we are so grateful to the family for continuing to come back and be a part of this process, to be active, to want to know what's going on in the program. That's so fulfilling for us that even after 4 years now, that there's still continued commitment and engagement on what we're doing to try and make things better for patients across the board. And that really is unique, and it truly it humbles us to be a part of that process. So I will stop blathering on and bring up the real star of the introductions. Dr. Puri is going to come up and always gives us a very important perspective on how this is important for the family and a legacy for Mr. Puri. So please come up.
Good afternoon and welcome you all to the 4th Surinder Puri Memorial Lecture. As Dr. Loniel just mentioned, I lost my husband 4 years ago, and actually this week he would have been 81 years old, which I have to pinch myself. I just want to tell a little story about him, and he was typical of non-Hodgkin lymphoma patients, almost 65-year-old, vibrant, healthy, engaged, highly functioning man who had a little eye droop one day and wanted it looked at, and of course was eventually diagnosed with stage 4 non-Hodgkin lymphoma. Needless to say, we were just so afraid, and I reached out to my angel friend, Dr. Majmudar, who's somewhere here, the retired professor of pathology, and said to him, "What do I do now?" And he said, "I know just the person to take care of Surinder." And of course, we found Dr. Loniel, which was such a good fortune. And Dr. Loniel and his team, I believe, provided him the state-of-the-art treatment available, and he did very well and thrived for almost 10 years when we got the rude reminder, and he relapsed. He was back at Emory with Dr. Loniel and had another 2 very good years, but unfortunately, some secondary septicemia took his life. But we have been so grateful to Emory for the care it has provided to my husband, and I think he did as well as to be expected. We wanted to thank Emory by creating something that we could give back by bringing the top researchers in the area so that we could collaborate, participate together, and disseminate this information in a very little humble way so that it could continue to help all the lymphoma patients. And we've had some wonderful speakers, and I am so delighted to welcome Dr. Ansell today, who will obviously give us very enlightening presentation. And I will like to sneak in the fact that he's a fellow immigrant who's doing whopping work for the medicine in US. So welcome, Dr. Ansell, and thank you.
Well, thank you, Dr. Puri, for that very warm welcome and nice reminder of Surinder's great contribution to all of us in terms of the things that he's done to enrich our community over time. And first, I'd like to publicly acknowledge the Puri family for this tremendous gift to Winship and the great contributions that it's made to us in the lymphoma program over the years. And I'd like to just thank them with a round of applause from everyone. This fourth annual lecture really has been a tremendous gift to us over the last several years, from wonderful speakers, from Brad Call, from Mike Williams, and also from Ash Elizadeh, who we've continued to collaborate with to this day in terms of the work that we've done in the lymphomas. We had a wonderful time spent last night at dinner and during the day yesterday with Steve Ansell, and today meeting with faculty that hopefully will lead to similar collaborations over time. Steve has been a longtime friend and collaborator, and so it is with great pleasure that we invite him here today, whether it's been times where we've worked together in terms of planning programs through the Leukemia and Lymphoma Society or through the Lymphoma Research Foundation, working on talks about the ways of management of follicular lymphoma, or sitting in a cafe in Ireland drinking a flat white together, trying to figure out what curse words our Irish cabbie said. Steve's been a longtime friend. I think he really has made some tremendous contributions to the world of lymphoma. As Dr. Puri mentioned, he is an immigrant coming here after completing his medical training in South Africa and his PhD in Pretoria, then did residency and fellowship at the Mayo Clinic, and then went on as faculty and has been there from that time really to the present. Steve has made some tremendous contributions both in the world of checkpoint inhibitors in lymphomas, being one of the lead authors and contributors to the development of checkpoint inhibitors in lymphoma, understandings of the tumor macrophage microenvironment and T-cell exhaustion in the tumor microenvironment, and is now the chair of the International Waldenstrom's Foundation and Society, and a leader in the scientific committee for the Leukemia and Lymphoma Society, and chair of the Mayo Clinic Lymphoma Program. So it's with great pleasure that I introduce my great friend, Steve Ansell, to come here and talk to us today. Thanks, Steve.
Well, good afternoon, everybody. Thank you very much to Chris and Saga for inviting me. Thank you to the Puri family for hosting this. You've been wonderful hosts and very gracious, and appreciate that a lot. Thank you very much to you as the audience for being here, and I hope that as we go through the next 45, 50 minutes or so, my goal is to make the whole role of modulating the immune and microenvironment hopefully a little clearer, but I think what I hope to show, and I'll go through this, is that we understand some things and we have many things yet to understand. So to the point that we just spoke about collaborations, I think the scientific community needs to keep their heads focused on how to really understand how to get the anti-tumor immune response optimized in a disease where the immune system is the enemy. And really trying to work out how to do that better is the challenging part. So I titled the talk Modulating the Immune Response in Lymphoma, with a subtitle, and I wanted to highlight mechanisms that impair this anti-tumor immune response and what we might be able to do about them. So I'm going to try and sprinkle in clinical things, going to show you some lab-related stuff, going to show you some patient-related specific data, with the hopes that everyone in the room would get something out of the talk and be stimulated to be thinking about how we can do this better. I need to start off and just disclose that Mayo Clinic gets funding from these companies for various clinical trials, and the results of these clinical trials are some of the data that I will be presenting. So what do I hope to do? I'd like to start off just to remind us that if we actually want to have an effective anti-tumor immune response, we need to understand what does that look like. So just take you back to the biology of what do you need to have a really good anti-tumor T-cell response? Because that's what we want to emulate when we're looking at ways to modulate the microenvironment and get the T cells working. I'm then going to show you that the microenvironment really is conspiring against an effective response. And there are multiple different mechanisms that need to be overcome. And although I'm going to show you some of the ways in which we've got success in being able to overcome some of those issues, I would point out that we may need to do multiple combinations of strategies to overcome the multiplicity of challenges that there are with barriers to an effective anti-tumor response. I'm going to talk about some of those ways in which there have been effective strategies developed. We're going to talk about immune checkpoint blockade. I think many people in the room are familiar with the fact that that's been a success in some diseases, but not so much in others. And I think what's going to be important is talking about why is that? Why does it work in some and not in others? Because clearly if we can understand what makes it work, we can then understand how to do more of that. And when it doesn't work, we can understand what we need to overcome. I'm going to talk a little bit about the innate immune system and how we can kind of optimize an immune response if we can get both macrophages and monocytes and T cells to collaborate and get a more targeted response to the tumor. And then combination approaches highlights that issue, but also highlights the fact that there are other tools and how can we actually put that together. And we're doing that, so the question is it working, and if so, why? And then right at the end, I'm going to sprinkle in the fact that we think we know what we're doing, but actually we don't. And I think, again, this is one of the humbling things about science, is every step forward is a step back right after. And I think part of understanding when it works is important, but equally it's important to understand when it doesn't. So I'm going to take you back to Biology 101. Probably you got this in high school, maybe you got it first year in college. But I think what's really important is to remind ourselves that if you really want to get an effective T cell response to an antigen, what do you need? Because if that's what we're going for, we've got to have all of those components in place. So the first thing that you need to do is you're going to have the antigen being presented in the context of MHC in a way in which the T cell receptor will engage with that antigen. And obviously signal number one goes back into a cell. Cell becomes activated, but at the same time, for that to be a persistent response, you need to get a second signal that comes to a co-stimulatory factor or co-stimulatory receptor. That would be the second signal. Subsequently, the cells become activated. When they become activated, the key things are they persist and they remain targeted, and memory is developed. And so overall, the important things to remember is that you need an effective recognition of the antigen, activation of the cells, persistence of the cells, and I probably should have put on there memory thereafter. So if that's what we're looking for, the key thing is, why are we not getting that? So these are some of the things, again, that are just normal biology. But if you actually, again, at the same time as having an activated first signal coming through the T cell receptor, get an inhibitory signal, you basically shut the cell down. And many times we'll talk about PD-L1 being such a negative signal. The tumors work that out. And it's a little bit like putting, when the police arrive and they put the yellow tape up around the building and they go, everyone who was watching, you guys can go home. The immune system gets told to go home and gets shut down by these inhibitory signals. The other thing that can happen is that you can get a first signal and no second signal. And again, that's a mechanism for anergy where you basically get cells that are unresponsive. And I'm going to highlight in a minute that these inhibitory T cell signals are very common, and sometimes lack of additional activating signals may also be an issue. And I know there's data from your group here, and I'm going to show you some data from our group, that if you look inside lymphoma specimens, in fact, that's an issue because many of the cells have lost CD28, have lost CD27, clearly have an anergic appearance, and those are cells that are right in the tumor supposedly doing the fighting and clearly aren't. So I think, again, we need to understand that better because we need to activate those cells. Shown here is a very nice review article written by Dr. Scott from Vancouver, but I think highlights some of the things that I'm going to show you sort of more detailed data related to. The first challenge, so remember we needed good antigen presentation, we needed co-stimulation, we needed persistence, we needed activation, we needed memory. Where were there deficiencies with each of those? And I'm going to highlight here firstly, and we'll show you some data in a minute, that MHC is often lost in lymphomas. Hodgkin lymphoma is a very good example of that. And when it's lost, antigen is not adequately presented. So again, if you want to have a good response, you've got to see the target. If there's no target to see, you've got a challenge. So that's one of our problems, loss of antigen presentation. Second thing is that suppressive ligand that we just spoke about. Many times overexpression of PD-L1, PD-L2, which are inhibitory signals, and so then even though the cell is activated, does see the antigen, automatically gets a negative signal, which shuts the cell down. And the third thing, and I think this is a little less studied, is there is an absolute soup of inhibitory stuff present within a tumor, and a variety of cytokines, immunosuppressive ligands, sometimes activating cytokines that activate for too long and then subsequently induce exhaustion. All of those things are present, so you really have a challenging environment. And finally, there are other cells present, many of them that are promoted by the activation of the tumor, or by the tumor, that then become suppressive. So we'll talk about suppressive T cell and monocytes populations that are very suppressive to the effective, hopefully, T cell response. So loss of antigen presentation, suppressive ligands present in the tumor, suppressive T cell and other populations, and suppressive cytokines are the four things I want to focus on and show you some data around that are very inhibitory. So even if you have a T cell ready to go, seeing the target, it's inhibited by all of these negative suppressive factors. So first thing to talk about is antigen presentation. So again, as I mentioned, important for a peptide to be processed, to be then presented to the immune system in the appropriate MHC context. The challenge, however, is if it isn't there, the MHC complex, how is the antigen then adequately presented? So these are data from Hodgkin lymphoma, and this is just immunohistochemistry, staining for MHC class 1, MHC class 2, and beta-2 microglobulin. So again, you can see there are positive and negative specimens, but what I would highlight is if you look right over here, black is when it's appropriately expressed. And looking at all of these cases, looking for each of these components to say that MHC is really perfect, if you like, it's a very small population in this study that are actually positive, just a few cases. So remembering that MHC is lost kind of in almost universally, at least 80+% of Hodgkin lymphoma patients, that's a real challenge to understand how is the antigen being presented. You might argue, well, maybe CD58 is one of the mechanisms for that, but CD58 is often mutated or lost in Hodgkin lymphoma cases. And you'd also know that PD-1 blockade has been highly successful in this disease. So one of the challenges is just if you think you're activating a T cell, what's the T cell seeing? Because it's not clear that at least the way we typically think of T cells being presented in antigen is effective and working in this disease. So you might say, well, that's fine and well, that's Hodgkin lymphoma. What about other lymphomas? So shown here is some data from Lisa Rimza, now 15 years old, but I think important because again, looking at HLA-DR and looking at loss of HLA-DR now in diffuse large B-cell lymphoma. And again, you can see that's very frequent, but most importantly, is highly associated with a risk of death. So I think when you look at different B-cell malignancies, Hodgkin on the one hand, diffuse large B-cell lymphoma on the other, MHC class loss is actually a significant issue, and so antigen presentation is imperfect. And so the question when we're looking at how to treat patients, we need to bear that in mind. Second issue that we mentioned is, well, what about at the time when a cell actually would be activated, it gets an inhibitory signal? How common, how much of an issue is that? And the bottom line is, it's a significant issue. So shown here on the left, again, is Hodgkin lymphoma, and as most of you will know, chromosome 9p24.1 is the locus for PDL1 and PDL2. That's very typically amplified, or there's increased copy number gain, and that's shown over here, copy number gain, amplification. Most importantly, it results in very high expression of PDL1 on the cell surface of Reed-Sternberg cells. And so that actually creates almost a wall, if you like, around the Reed-Sternberg cell of inhibitory protective ligands. So you might say, well, I know that. That's kind of common knowledge, but I would point out that the same challenge is true in diffuse large B-cell lymphoma. So shown here in blue is when PDL1 is overexpressed on the actual malignant B cell in diffuse large B-cell lymphoma. Shown in the green is different cases here where it's overexpressed in the microenvironment on macrophages and other cells. But I think what's important to know is that almost all cases there is some degree of upregulation or a fairly significant amount of expression. And when they made a cut point at around 30% of cells and looked at outcome, when there's more PDL1 expression, those patients do more poorly. So I think what's important to recognize is inhibitory ligands are very commonly present in a variety of different B-cell malignancies. So again, what's important is the ligand's present, but are there cells that are susceptible to inhibition by PD-L1 present in the tumor? So it doesn't really matter if you have high amounts of PD-L1 if there aren't PD-1 positive cells around. Bottom line is there are lots of PD-1 positive cells, and shown here is if you look at the CD4 fraction, CD8 fraction, and now we're looking at follicular lymphoma, you can see that if you look for PD-1 expression and TIM3 positive cells, you can see sizable populations that are present. So these are cells that look exhausted, expressing PD-1, susceptible to ligand interaction and apoptosis and inhibition, and so they're present and you can see them. But the next question is, well, so they're there, but are they really exhausted? So we spent a bunch of time trying to understand that. Shown here is that if you activate the cells, do they proliferate? Shown in the white are the control cells, and again, many little peaks happening here, so you can see these are cells that easily proliferate. But if you specifically look at the TIM3 positive, PD-1 positive cells, the exhausted cells, you can see they have no little peaks, hence they're not proliferating at all. When we've looked at their ability to make cytokines, the cells that are positive for both, you can see don't make cytokines at all. They don't signal very well. So in general, not only do they look exhausted, they functionally are exhausted. So problem number 2 is you've got inhibitory ligands and you've got cells that are susceptible to being inhibited, again, in the same tumor. The third issue is sometimes you have a neighborhood, what does Aesop say, that a man is known by the company he keeps, and sometimes the company within the microenvironment is not all that good, lots of inhibitory bad influences, if you like. So when we started out a lot of this work, the key thing that we were interested in is looking to see how many CD3 positive T cells were present in follicular lymphoma, thinking that if there are lots of them, they would be good because they would be able to inhibit the malignant clone because they would be right there ready to do their job. So when you look at it, follicular lymphoma, you can see these pseudo follicles, but if you stain not for CD20 for the malignant cell, but for CD3, you can see lots of brown staining. And if you look for follicular dendritic cells, you can see these follicular meshworks. So a lot of immune cells present within the microenvironment. And if you dive a little deeper right into that follicle, you can see CD4 and CD8 cells right in the tumor, right at the tumor site where the malignant cells are. So clearly these have got to be good cells, got to be helpful because they're right where they need to be to do the business of taking care of the tumor. Well, not so fast. When you dig a little deeper, many of those cells that are right there are Treg cells, or regulatory T cells, with a suppressive function. So if you stain for the same follicle now for FOXP3, you can see most of those CD4 positive cells are actually Treg cells. And if you enumerate that by looking at lymphoma compared to control tissue, you can see this persistent population of Treg cells from patient samples now taken right out of the patient. If you take those cells and co-culture them with other T cells that are present within the tumor, you can see that increasing those number of cells suppresses their ability to make cytokines, and shown over here suppresses their ability of the other T cells to proliferate. So lots of Tregs right in the tumor, highly functional, and suppress the function of other T cells. Similarly, many would know that many tumors have lots of monocytes and macrophages present within them. So this is here a staining for 163, with CD163, which is a marker of macrophage monocyte lineage cells. When we looked at their ability to make various cytokines, we'll show you in a minute, IL-12 is an activating cytokine, but too much of a good thing often ends up being a bad one, and it actually induces exhaustion, and the macrophages are responsible for a lot of that cytokine production. If you take patient specimens and you take out their macrophages and you co-culture them with the malignant B cells, as you add in macrophages, those B cells grow and proliferate. And if you're here in a mouse model, here what we're doing is we're just taking a tumor cell line, co-culturing or adding in macrophages at the same time and measuring the speed of engraftment or growth of that tumor. You can see the tumor grows pretty well, but if you add monocytes and macrophages into the spot where you actually inject it into the mouse, you can see it engrafts even faster. So number one, we've got lots of inhibitory Treg cells present. Number two, the big challenge is that many of the monocytes and macrophages are promoting the growth of the malignant cells. So hence a lot of facilitators rather than targeting effector cells, promoting the growth of cells. Final group of cells that is also not helping are myeloid-derived suppressor cells. So we've specifically focused now on the HLA-DR low population, that is lineage negative. We've looked at the CD11b population and then split out the CD14 versus CD15 positive myeloid-derived suppressor cells. And if you look here, we used Waldenstrom's macroglobulinemia here, where we're looking at cells that make a lot of IgM. But you can see that whether you look at each of these populations, in each of the cases, the tumors have far more of these cells than control normal bone marrow. If you take those cells and you co-culture them with T cells, you can see that they significantly inhibit the proliferation of T cells. So really 3 different populations of other cells present right in the tumor, none of which are helping the T cells be effectively able to target the malignant cell. Too many Treg cells, too many macrophages and monocytes, and myeloid-derived suppressor cells, all of them again influencing the T cells to not do a good job rather than target the malignant cell. And finally, I mentioned the soup of stuff that really isn't all that helpful. And those really come in 2 kinds of flavors, if you like. There are cytokines that actually we know that generate a more kind of suppressive environment, but there are also cytokines that we would have thought to be a good idea because they would activate the immune system. But as I'll show you in a minute, persistent activation is like pouring gasoline on a campfire. You get a massive blaze and that's all really good, but it doesn't stick around. And you heard me say in the beginning that persistence is really an important issue, and that's where we get cells that kind of peak and then become rapidly exhausted. So shown here is IL-10. We've specifically focused on the fact that you get the CD14 HLA-DR low, very suppressive monocytic cell, highly expressed in lymphoma. When you take these cells and co-culture them with T cells, they decrease the ability of those T cells to proliferate. And if you add IL-10, you can generate this phenotype. So this just shows as your dose of IL-10 goes up, you get more of these CD14 HLA-DR low cells. And you would say, well, so who cares? But just to point out that if you look at B-cell lymphomas, you get increased amounts of IL-10 present in the serum of patients that have lymphoma, in this case, large cell lymphoma. This just comes back to what I said a minute ago about sometimes too much of a good thing is a bad thing. So this is just looking at cytokines. I'm going to focus in a minute on IL-12, which would activate your T cell response and potentially would be good, but may not be so much. Here we show TGF-beta kind of induces the CD470 positive population of T cells, an activated T cell. But if you look at that population of CD70 positive cells and look at their expression of those exhaustion markers, PD-1 and TIM-3, you can see the CD70 population is much higher. There's far more in the way of TIM-3 and PD-1. Those are also the cells that don't proliferate, and those are also the cells that don't make cytokines. So again, when TGF-beta kind of activates these cells, you actually get an exhausted phenotype rather than an effective phenotype. Similarly, we found that IL-12, if it's elevated in the blood of patients with follicular lymphoma, those patients do worse. And one of the things that was curious, we did a clinical trial where we actually were giving IL-12 with rituximab, the goal being to activate T cells while you actually depleted the malignant clone. We actually found that that was worse than giving rituximab alone. A little bit of a head scratcher, why that was, but we found that if you give IL-12, you actually promote this population of TIM-3 positive, PD-1 positive cells. So persistent activation of the immune system activates a cell, but over time makes it an exhausted phenotype type cell. So with that as a background, again, just reminding you this challenge of multiple different systems that would kind of conspire against an effective immune response. The cell can't really see the tumor very well because MHC class 1 and 2 is commonly downregulated or lost. 2, there are actually other inhibitory cells that suppress the function of the effector T cells. Thirdly, there are a variety of different cytokines, all of which would specifically suppress the function of the immune system. And finally, there are actual active ligands that would deactivate cells that would express PD-1 and have an exhausted phenotype. So with that in mind, what do we need to do? Well, I guess we need to reverse that T cell exhaustion, but at the same time, we have to overcome the immune suppression. So I'm going to show you data on how we've been trying to do that, but I guess as a group, I would have us to continue to think about how you do that well, because it's a balance where when you tip things this way, many times things fall off on the other side. So how to do this and hit the sweet spot is the real challenge. When all is said and done, we would like this lymphoma cell to be targeted and effectively eradicated. So strategy number one, and this is one that most in the room would be quite familiar with, is, well, if we just block that inhibitory signal. So shown here is the T cell receptor engaging with MHC-expressed various antigens that are being presented within MHC context. And you can see there are a variety of different inhibitory signals that could be provided. And I'm going to focus in on PD-1, but as you know, CTLA-4, a variety of others, LAG-3, are all focus of a variety of different antibodies. But the idea being that instead of allowing a negative signal, if you block that negative signal, then hopefully all you'd get is a positive signal, and that would be activating to the immune system. So the key question is, does it work? And the answer is, in Hodgkin lymphoma, absolutely. So I show you two patients from the original nivolumab trial. And I'm going to show them for two different reasons, because very gratifying to see patients benefit from treatment, but challenging to understand exactly what we're doing. So I want to set the stage, because as we kind of go through the rest of the talk, I want us to think, I'm going to sprinkle in some of the challenges of when we think we know what we're doing, we realize we might not know as well as we think we do. So the first patient here, you can see if you're in the abdomen here is a lot of FDG-avid lymph nodes. And you can see that within 6 weeks of treatment, the patient has had an excellent response, and that's all gone. But the astute clinicians in the back of the room would go, well, what's happening in the chest? Because here's FDG avidity that you can see, and that hasn't gone away. Well, the interesting thing is this patient had her valve replaced right around the time that we actually put her on the trial. So it would suggest that when you have cells that are activated and part of a healing process, they're not as easily inhibited by PD-1 blockade as what's going on in the abdomen. The second patient shown here is actually one of the very first patients who went on the trial. Very gratifying, because his mom called up and said, he's 26 years old, they just told him he's going to hospice. They got absolutely nothing to offer him. Do we have anything? And as it had happened, we had just opened the phase 1 clinical trial, and we said, you know what, have him come down, we'll give it a try. So he got his treatment, and he called me from the car on the way home and said, it's working. I'm like, yeah, right. But he said, no, I stopped itching. So it's working. And he was right, because he had a phenomenal result. You can see all this massive lymphadenopathy. I mean, he couldn't even put his arms down because he had such big lymph nodes under his armpits. But you can see that within 6 weeks, he just has this little bit of uptake in his armpits. Now, what's interesting, though, he kept that little bit of positivity all the way through the 2 years that he was allowed to be on the trial. And at the end of 2 years, the trial required him to stop. And about 8 months later, this was getting worse. So again, the trial allowed us to restart, and we restarted, and he responded again. And that was very gratifying, but as an immunologist, it was very disappointing, because no immunological memory. Because if the T cells were really seeing those tumor cells and really killing them, there shouldn't have been a need to retreat, because when it got reactivated, those T cells should have come rushing back and finished the job. And they didn't. So that's got me a little puzzled to go, well, what's really happening? And I'm going to show you some data as we go through as to what we think might be going on. But clearly that's one of the challenges for us as a group to be thinking about how to understand that better. This was then confirmed in a phase 2 clinical trial for nivolumab. This waterfall plot shows all the patients that have benefited. You can see it, more than 2/3 of patients have had at least a 50% improvement, but I point out that virtually everybody had some degree of response. The sobering note is these curves here showing patients failing doesn't plateau. They keep going down. So we're not fixing people with PD-1. So those of us that are working on new immune checkpoints, job's not done, because unfortunately over time, patients are progressing. Same is true for pembrolizumab. You can see, again, very similar waterfall plots, great responses, but again, you can see the majority, whether you looked at people who were pre-transplant, or transplanted plus brentuximab vedotin before or after transplant, didn't matter how you diced it, patients benefited, but the challenge was just that they continued to progress. This obviously looks at, well, if you block the PD-1 receptor, that's the strategy most of us have been using, but what about if we block on the PD-L1 on the ligand? Well, the data looks pretty similar. The response rate may be a little lower, but you can see the waterfall plot has very much of the same pattern, suggesting that it might not matter which side of the axis you end up blocking. So lessons that we kind of have learned from this that we might be able to apply to other diseases, and I'm going to show you in a minute how this might work. Can we take what we're learning in Hodgkin lymphoma and use it in other B-cell malignancies? So the first thing that I think is important is that overexpression of PD-L1 does seem to have some degree of correlation with outcome, but it might not be that useful. So what I mean by that? Well, copy number gain and amplification is very common in the vast majority of patients. And if you look here, that results in overexpression of PD-L1. So using this PD-L1 H-score, you can see that whether you have copy number gain, amplification, the expression of PD-L1 goes up. And that actually translates into differing outcomes for patients. But the reason I say it's not that helpful is almost everybody is in this curve right here. So these are the copy number gain amplification cases, which is almost everybody, and they kind of are overlapping. So it's not actually that helpful because everyone has screamingly high PD-L1, and those people all do about the same. The second thing that we learned is that it's not just about this overexpression on PD-L1 on the Reed-Sternberg cells, but there is actually a moat of PD-L1 expressing macrophages that are commonly in the kind of growth niche, if you like, of Reed-Sternberg cells, and these are also very protective, kind of forming a shield, if you like, to keep the effector cells away from the tumor. So it's not just about getting these cells inhibited, it's obviously getting these ones out the way. But could we take some of that information, this amplification story, the reason to have a very high expression of PD-L1, and use it in other diseases? And the answer is yes, absolutely. So this is moving now to primary mediastinal large B-cell lymphoma, again in about a quarter of patients here, maybe to 30%, the same amplifications and overexpression can happen, and overexpression in general is common. And you can see that the response rates here are not quite as high as Hodgkin lymphoma, but still 44%, pretty reasonable. The waterfall plot, not identical, but still a high percentage of patients benefiting. And as most in the room would know, EBV also drives overexpression of PD-L1. So if you take a disease like the NKT cell lymphomas where EBV drives the process and treat those with PD-1 blockade, does that work? Small series here of 7 patients, but 5 out of 7 showed a significant response. So if you have a genetic reason or a reason such as EBV to have high levels of PD-L1, those seem to be diseases where you get good responses. Interestingly, you also get good responses in Richters transformation. So for those that might not know, CLL, or a low-grade lymphocytic leukemia, when it transforms to a more aggressive lymphoma called Richters transformation, that transformation is where you see responses. So in the trial that we did, we found that when you treated patients with CLL, those with just the straight CLL, none of them benefited. But interestingly, in the patients that had Richters transformation, and you can see this overexpression here in the abdomen, much improved, these lymph nodes in the armpit, much improved, about 40% of the patients had a good response. But I think what was really curious, in the same patients where they had a real significant response in the Richters part, the CLL didn't care. It continued to progress, and we actually had to give additional CLL therapy to try and control that component. And we went back and we sequenced the heavy chain of both of those clones to say, what's with that? And they were identical. So for some reason, the immune system could see the Richters, but it couldn't see the underlying CLL. So again, just tells us we have more to learn in that whole area. The other thing that's curious, and we were talking about this yesterday, is if you actually look at the staining, PD-1 was expressed on the Reed-Sternberg cells, on the Richters cells, which was kind of different from what is in large cell lymphoma, and I'll show you that in a minute. Little sobering note though, so everyone got super excited about the results in Hodgkin lymphoma. If it's good in Hodgkin lymphoma, it's really got to be good for most lymphomas. We've tested it in low-grade lymphomas. So this was a trial that was the companion trial to that CLL trial, again using pembrolizumab in a variety of low-grade lymphomas. The sobering note is the overall response rate here is only 11%. We just published this a few weeks ago, but this is now a large study in large cell lymphoma for those that either had a transplant and failed or progressed and couldn't even get to transplant. And I think just cutting right to the chase, you can see these waterfall plots are very disappointing. Overall response rate post-transplant is only 10%, and for those that couldn't get to transplant is only 3%. So clearly, blocking the inhibitory signal in a patient with diffuse large B-cell lymphoma is not the answer. And again, much enthusiasm around immune checkpoint therapy, we persist with this, but just reminding you that back in the day, if you had a chemical that had a 10% response rate, we would have kicked that to the curb and said that's not good and moved on to other things. So I want to highlight some of the complicating factors. So we've got a disease like Hodgkin lymphoma or primary mediastinal large B-cell lymphoma where you get really encouraging results. Then you've got follicular lymphoma and you've got large cell lymphoma, and it's really kind of rubbish. So the question is, what can we know about why is this happening, and what are the complicating factors that may account for some of that? So the first thing I want to just point out is that just because your cell expresses PD-1 doesn't mean it's exhausted. So the first thing is, in follicular lymphoma, you might remember I showed you those pseudo follicles, and you can see that when we stain for PD-1, those follicles stain very brightly for PD-1. But if you look carefully, in between the follicles, there are dimly positive cells as well. We spent a lot of time showing that these cells that are in the follicle are T follicular helper cells. And these cells that are between the follicles are the ones that have more of the exhausted phenotype. So when you block PD-1 just across the board, you're doing different things to different cells. And when your disease has both populations, we don't really know what we're doing to a T follicular helper cell by blocking PD-1 relative to what we're doing to an exhausted effector cell by blocking PD-1. Shown here is that, interestingly, when we try to understand exhausted cells, and so we were isolating PD-1 positive cells, we found the PD-1 positive cells made much more in the way of cytokines than the PD-1 negative cells. And we were like, well, what is with that? Well, it turns out, as shown here, just because you have PD-1 positivity doesn't mean you're exhausted. When you activate a cell, the first thing that goes up is PD-1. It's a regulatory receptor. You need to express things like LAG3 and TIM3 and other exhaustion markers before you are exhausted. So shown here is the PD-1 positive fraction that does all the production of cytokines. But when you look specifically at the ones that also express LAG3, you can see it's only the LAG3 negative population that is PD-1 positive that actually makes the cytokines. When you have LAG3 positive, those cells don't make cytokines at all. So again, I think the important principle is we are just indiscriminately blocking PD-1 signaling, but we're doing different things to different cells. Touched on this a minute ago, just wanted to circle back for a minute. This is comparing those Richters patients from CLL to patients with diffuse large B-cell lymphoma. And why is that important? We think of PD-L1 overexpression as the important issue. You can see that in Richters, where these patients respond quite well, PD-L1 is present, but not super high. What's super high, and I know one of your fellows are looking at this, overexpression of PD-1 on the malignant cell. So now, what exactly are you doing when you're blocking PD-1? Is that a signaling issue? Because you would think that if you blocked an inhibitory signal on an activated B cell, that should be a positive thing, right? Should actually cause that cell potentially to become more kind of activated. And yet we see responses, so maybe the mechanism is very different. This was data from Margaret Ship's group looking at which cell in Hodgkin lymphoma is the PD-1 positive cell. Because if we're arguing that we get wonderful results clinically when we block PD-1, the question is, where are those PD-1 positive cells? And interestingly, when she compared to lymph nodes and tonsil, you can see the sizable population of PD-1 positive cells are actually Th1 positive Treg cells. So when you're blocking an inhibitory signal on an inhibitory cell, what is that doing? So that doesn't make a lot of sense. The cells that we would have hoped there'd be more of were these T1 effector cells, and actually they have very modest PD-1 expression, and there are not that many of them. Additional kind of complicating factors, and I know we've discussed with some of the faculty that this is something that others are seeing too. Well, firstly, let me just say, we actually see the same population of PD-1 positive Treg cells in follicular lymphoma. So this is some data from CyTOF. I'll just have you focus in here. Here are the CD25 positive typical Tregs that are FOXP3 positive. You can see there's very little PD-1 positivity there. But if you look at the CD25 FOXP3 positive second population here, you can see those are very bright as far as PD-1 is concerned. You can see them highlighted with PD-1 expression right over here. So this population is present in other lymphomas as well and present in Hodgkin lymphoma. This is what I was touching on in just a minute ago, and others from your group have shown the same, and that is that when we look at follicular lymphoma, we see something that's pretty interesting, and that is CD28 and CD27 are actually downregulated. So specifically when we look at follicular lymphoma and we look at the percentage of cells that lose 27 or lose 28 or lose both, you can see the percentage is significantly higher in follicular lymphoma and really not a thing in normal control tissue. Shown here is, does that matter? Well, yes, because those that don't lose CD27 actually do much better than the patients where CD27 or 28 is lost. So all told, that clearly appears clinically relevant, and the issue might be when it comes to PD-1 blockade that this matters a lot, because there have been 2 papers in Science a year ago showing that when you block PD-1 signaling, what you're really doing is driving signaling through CD28. And so in other words, no inhibitory signal, but instead the signal gets driven toward a positive activating signal. The challenge is if the receptor that was supposed to give the activating signal is downregulated or lost, how is that going to work? So I think, again, things that complicate our understanding of how this all works. And finally, I think it's important to recognize that we spend a lot of time focusing on what's happening in the tumor, but sometimes the tumor microenvironment may only be part of the story. Maybe it's the patient macroenvironment that matters a lot too. Because I think what a lot of people forget is that PD-L1 is actually shed and circulates in the blood. So shown here is in Hodgkin lymphoma, you can see PD-L1 and PD-L2 far higher than control patients or control subjects. If you take that PD-L1 and PD-L2 and check the stimulation of T cells and then add in PD-L1, you can see significant inhibition of T cell function by soluble PD-L1. You can see that inhibits the signaling here of phospho, ERK, and AKT. Shown here is the ability, again, this is looking at metabolism studies, and you can see that this is significantly decreased with the presence of soluble PD-L1 and PD-L2. So it may not just be that you're inhibiting T cell function right in the tumor, you may be globally inhibiting T cell function. So when the immune system calls for help, tells the T cells to come on and do something, even the ones that show up are the ones that are already significantly inhibited. And finally, I think just a little controversial maybe, and maybe a little challenging to our thinking. As an immunologist, I kind of hesitate to say this. Maybe it has nothing to do with T cells. Maybe it's reverse signaling through PD-L1. So shown in normal T cells, this is a well-described phenomenon, that binding of PD-1 to the PD-L1 ligand drives a signal back into the cell. So we used an agonistic antibody that binds to PD-L1, and you can see in all of these Hodgkin cell lines, it actually increases the proliferation of the cell. When you then said, well, is that relevant? Well, soluble PD-1, so now the actual receptor is also detectable circulating around in the blood. And we show that when that binds to the PD-L1 on the Reed-Sternberg cell, again, you're promoting growth, and if you add in nivolumab, you can significantly inhibit it. So maybe there's really just an agonistic signaling going back into the cell via PD-L1, that when you interrupt that agonistic signal, you shut the cell down, it stops making all the cytokines that was recruiting the immune system, and things improve. And I circle back to my patient that called me and said, I stopped itching. We had a similar patient in the clinical trial treated outside of the US, where due to a scheduling error, they got a PET scan the day after they gave the chemo. They gave the anti-PD-1 antibody. Again, I'm no insurance company would let that sneak by here. But the very next day, the patient was in a partial remission. And you go, how does that happen? If you just woke up the immune system, sent the T cells in, the guy should have been exploding. It should have been like a cytokine release syndrome. And yet he was already improving. So question might be, maybe you just take away an agonistic signal rather than recruit in immune cells. So with the last few minutes, going to talk a little bit about, we spoke a lot about T cells and really trying to get them to work better. What are some of the other strategies that we could focus on? Well, maybe we can engage the other part of the immune system, the innate immune system. So if you like, the quick and dirty response, the bouncer at the door of the club who just kind of beats you up a little bit while we wait for the cops to come. So we're looking now to get the macrophages to eat the tumor. And many would know that the tumor cells have got smart to that too, because normally what happens is your cells age, or if they become malignant or virally infected, they begin to put eat me signals on the cell surface. If they don't want to get eaten, they have to then provide a don't eat me signal, and CD47 is one of those. So if CD47 is present, signals through SERP alpha, and the macrophage gives this cell a pass. It's a little bit like TSA pre. You know, you get to go through because they kind of trust you, but if you lose your TSA pre, they make you take your shoes off, you know, you got to strip half naked, and in essence, what we're trying to do is to do that, is to try and make the innate immune system look at the tumor cell a lot closer. So blocking the don't eat me signal causes the macrophage to look over a tumor cell a lot closer. That's what's shown here, and I'll show you some data for CD47 blocking antibodies or the SERP alpha decoy receptor. So it blocks this don't eat me signal, which really then leaves the eat me signals for the macrophage to come and take a close look. So hopefully the macrophage then phagocytoses the tumor cell, presents the antigen now in a much more usable fashion, and it causes the T cells to get mad and grumpy, and they show up to kind of finish off the tumor cell. That's what we would love to see happen. So does that work? Well, in lymphoma, actually quite promisingly so. So this is the clinical trial with the anti-47 antibody from the company 47. You can show that there's good receptor occupancy. Shown here are two patients. You can see the FDG avidity in the chest that gets dramatically better. You can see this patient with lots of spots, all much better. You might argue, well, what happened here? Well, the patient had a pleurectomy, and so a lot of that is part of the healing, but all of the sites of malignancy were negative. This just shows you the response rates, now using rituximab, the anti-CD27 antibody, plus the anti-CD47 antibody and the anti-CD20 antibody, and you can see good response rates in about 50% of patients that seem durable. So this actually has resulted in breakthrough designation for this antibody in combination with rituximab. Similar data starting to come out now with the SERP alpha blocking antibody, the TTI-621, and you can see a large cell lymphoma patient here with very nice response, complete remission. The response rate's a little lower, about a third of patients. Again, benefit seen if you add this with rituximab. So can we make the innate immune system work with the T cells? That may be a place to really look in the future. What about we take some of the other things that we've got and put them together with immune checkpoint approaches and immunological approaches? So we could spend a lot of time now talking about CAR T cells, but I will leave that to another speaker at another symposium. But I'm going to talk more about what works in Hodgkin lymphoma, and then can we translate that into, are the same things working in non-Hodgkin lymphoma? Because remember, we had a success story on the one side and an absolute not success on the other. So the first thing you could do, follow the lead from melanoma and other diseases. If one checkpoint was good, two's going to be better. Because obviously, if you are able to block the tumor T cell interface and get rid of that inhibitory effect, but at the same time you can block some of the inhibitory times when there's antigen presentation happening, you could get an even better result. Question is, in Hodgkin lymphoma, is that true? Well, you see an overall response rate in a small percentage of patients, small study, of 74%. And you might say, well, that looks a bit better than the 65 to 70% that you might have seen with nivolumab in this case alone. I would remind you, though, that if you really look closely at some of the subsets of patients, this is not a very different number to what you might be able to get. So this is going to take a large randomized trial to really show that there's improvement. In melanoma, it doubled the results. Here, this is not quite as good. So I think we have to be a little skeptical about, does this work? Second approach you could do is, what about we bring the NK cells in? So this AFM13 is a CD30 on the Reed-Sternberg cell, CD16 on the NK cell, bispecific engager, brings these two together with the hope of lysing the cells. Doesn't work that great on its own, so overall response rate only about 12%. But in Hodgkin lymphoma, small cohort of patients, you can see that response rates about 83%. So maybe this is something that's a little better, but we still have to do a much larger trial and randomize it to see if that's really the case. What about we use chemotherapy on a stick? So we basically deliver the chemotherapy right to the tumor cell. So brentuximab vedotin, many who treat Hodgkin lymphoma would be familiar with. And this is looking at binding to the tumor, gets internalized, directly targets and kills the cells. Highly effective as a single agent. And when you combine it with nivolumab now as the first-line therapy for relapsing patients, you can see a very nice response in a majority of patients. So the overall response rate about 82%. I think what's really encouraging is a CR rate of about 60% in this population. So maybe that's the way to do it. Directly to target the tumor as the tumor dies. Hopefully immunogenic death happens. Cells are presented with antigen that can then be targeted by T cells. This just highlights some additional data. This is brentuximab vedotin using nivolumab and ipilimumab. And again, the response rates are very high in this ECOG study with a CR rate that looks very promising. But I think what's most interesting to me is they had a variety of different populations. So they started off with brentuximab plus ipilimumab, and you can see the CR rate was about 57%. Then they did brentuximab plus nivolumab. Response rate looked a little better. When they took all comers in the triplet, you could see the response CR rate even a little higher. When they went with just the ones that were evaluable, you could see the response rates even higher yet again. So maybe an immune checkpoint approach plus an antibody drug conjugate has real promise in Hodgkin lymphoma. Added to chemotherapy right up front. I think what's important here to see is that this was when patients received nivolumab alone. You can see an overall response rate of 67%, which with chemotherapy then following shortly thereafter went up to 84%. But if you stopped me and said, well, tell me, is 84% really that much better than you could have got from chemotherapy alone? It'd be a little hard to say to you for sure that's true. So again, there's a randomized trial in development right now comparing AVD chemotherapy plus brentuximab vedotin versus AVD chemotherapy plus nivolumab. So with that as the success stories in Hodgkin lymphoma, if we switch directions and say, well, how are those types of strategies working where PD-1 blockade was not that great? Are we getting better results? Is that a place where we get a better signal? And the answer is not so much. So here is B-cell lymphomas, not Hodgkin lymphoma, small cohort, but a response rate that only looks pretty disappointing at 20%. As you can see, a majority of patients showing direct progression and not significant benefit. So simply adding 2 checkpoints may not be any better than adding just 1. This data was looking at adding an antibody to try and directly deplete the malignant cells, so rituximab plus pembrolizumab. I'll cut just to the chase here. Overall response rate doesn't look that different to what you might expect from rituximab, but the CR rate looks a bit higher. So maybe using a depleting antibody to get rid of the B cells, which may be driving the process, and then using an immune checkpoint may be a way to go. This was just published last week, but I think is important. Many folks have said, well, if you can modulate how T cells work by using a BTK inhibitor that also affects ITK, as many would know, the ITK molecule regulates Th1 versus Th2 balance and favors a Th1 response. Could you actually get a better result by adding nivolumab and ibrutinib in combination? And I think the most important thing is to note that the response rates were felt with the combination to not be any better than ibrutinib alone in the majority of diseases, with a little bit of promise maybe in Richter's transformation. But simply just trying to tweak the T cells in this case didn't seem to be the answer. So can we just take it to chemotherapy? Can we use R-CHOP chemotherapy, which is the standard for large cell lymphoma, and add pembrolizumab? And the answer is you can do it. Question is, does it work any better? We don't know yet. So you can see this was a small study of just under 30 patients. CR rate looks kind of what we would expect from R-CHOP. So I think we still have a little bit of time before this data matures, and we'll need a randomized study, which is in progress, to determine that. So what do I hope you've heard? And what do I hope you are thinking about? And in your research, you're kind of considering different things that we may yet need to understand. So I think the first thing is just to recognize there are many immunological barriers to an effective anti-tumor immune response. And we may be naive in just assuming you can tweak one thing and it will fix everything. We're going to need to potentially take a strategy of doing multiple things. I think secondly, genetic alterations matter. I think that's a population where clearly there's benefit. The question is it immunological? And the answer is, I think there's data that suggests that in part it might not be. I think it's also important to recognize that when you block something, you may do different things to different cells. So it's important to realize what are you doing to one population versus another, because that's going to matter. And finally, I do think combinations are going to need to be the future. The question is just which combinations. And we really need to try and be rational as we do this, because there are so many drugs and only so many trials. And we need to work out a way to try and understand which direction we want to go, rather than just sort of empirically treating all of them. I will just say one thing. I don't think you want to be too quick to toss out chemotherapy. Everyone hates chemotherapy because it affects the immune system. But I'd remind you that I think the malignant cell, whether it be the Reed-Sternberg cell in Hodgkin lymphoma or the malignant B-cell like in diffuse large B-cell lymphoma, it directs the show. A lot of the time, it's generating the microenvironment. So if you don't have a way to directly get rid of that cell, you can't really fix the problem as far as the whole microenvironment is concerned. So with that, I'd like to thank the members of my lab. I'd like to thank the funding organizations, and mostly I'd like to thank you for your time and attention. Thank you.